So we're at an incredibly exciting time in the field of epilepsy in terms of not just treating the symptoms of the disease, the seizures, but also treating the underlying causes and having true disease-modifying therapies. For the first time, we're really starting to understand some of the fundamental mechanisms that lead to development of epilepsy and are increasingly able to target them for therapies that will really change the course of the disease. The best examples we have right now are in genetic epilepsies, where we have gene therapies that are approaching and treating the underlying genetic causes of epilepsy. And watching the development of those therapies is very exciting, and some of them are on the cusp of becoming available to patients. We've also had a few single patient, or what are called N of 1 studies, utilizing novel approaches to genetic or genomic therapies that have been quite successful. Our issue now really is, how do we scale that up? How do we go from being able to treat a single patient to many patients? And that will be the challenge, I think, of the next few years. And also to go beyond therapies where we know there's a single gene disorder to the more common epilepsies, like acquired epilepsies. Those undoubtedly have some genetic susceptibility, but there's a process that happens after a precipitating injury, such as traumatic brain injury or stroke or an episode of febrile status epilepticus in a child, that then combine with the genetic susceptibilities to result in epilepsy in over half of our patients. Understanding what those mechanisms are and the commonalities between them will really help us target potentially the acquired epilepsies as well as the single gene-based epilepsies. And that will open up the options for disease therapy to many, many more patients with epilepsy. Right now, unfortunately, when we see a patient that has an injury that we know is likely to cause epilepsy, a moderate to severe traumatic brain injury, a stroke, hypoxic ischemic injury, and people of any age, what we can do is worry. We can tell the family to look out for signs, and we can treat the seizures if they occur. Where we want to be is to understand how that process is going to unfold, who is at the highest risk of developing epilepsy, and then be able to target the changes that are happening before epilepsy starts to potentially prevent it, or at least prevent it from becoming severe and pharmacoresistant. And I think we have a lot of clues onto how we can do that. We know that there are some pathways, such as the mTOR pathway, the JAK-STAT pathway, some other BDNF-related pathways that seem to be key players in that process of going from a precipitating injury to development of epilepsy. And as we figure out when and how to best target those cell signaling pathways, we may be well on our way to developing true disease-modifying therapy to either prevent or reduce the severity or progression of epilepsy.